Hello, everyone, and welcome. This is our fourth Grand Round series. And today's topic is the integrated care approach to address medical and psychiatric complexities with individuals with autism and IDD. So welcome. In front of you today is the team of presenters, and I have the honors of introducing them to you today and telling you a little bit about them. And then they're going to work out a plan to orchestrate themselves in the front row. So first we have Esmond Herry. I think everybody knows Esmond. Esmond joined Woods in 2023 as a certified nurse practitioner. Esmond provides a wide range of services focusing on assessing, diagnosing, and managing acute and chronic conditions. He is a compassionate provider who uses his knowledge, skills, and clinical expertise to provide safe, evidence-based patient-centered care to his patients. He received his bachelor's of science and Master's of Science in Nursing from Gwynedd Mercer University, and is currently, there's a lot of acronyms behind his name, an ACLS, BLS certified, and holds an AANP board certification. And for those of you who weren't a part of the earlier conversation, Esmond has a really great perspective on how to manage stress. So come and talk with him afterwards. Monica and I certainly are. And Holly, he is upstaging you completely. Next, we have Vida LeMaire. Vida is a certified nurse practitioner. She joined the medical center at Woods, the team there in 2018. She's been with us for 6 years or more as a family nurse practitioner. She has more than 13 years experience in a variety of healthcare settings, working with many different populations. In addition to her family nurse practitioner license, she recently also obtained her psychiatric nurse practitioner certification. Is that right? That's right. Vida received her Bachelor of Science from the University of Science and Technology in Ghana, a post-bachelor in nursing from the University of Connecticut in Stores, and got her master's in nursing from LaSalle University in Philadelphia. We're lucky to have her too. Keelin Milligan. Keelin is a licensed psychologist for Woods Community Services and the Center for Behavioral Health at Woods. She's the clinical director for WCS and oversees the clinical treatment and specialized for the community-based adult group homes. She also completes intake assessments and conducts the diagnostic autism assessments. She earned her Bachelor's of Arts in Psychology from Villanova, and then received her doctorate in clinical psychology at the University of Hartford in Connecticut. And she has extensive experience working with complex youth in a variety of residential settings. And next, we have Katrina Walker. Katrina is a registered nurse in PA and in New Jersey. She is the director of nursing for WCS. She earned her Bachelor's of Nursing in 2018 from Penn State and is currently attending Capella University for her master's. So Katrina, she's a member of the American Association of Critical Care Nurses and the American Nurses Association. She's worked with the IDD and autism communities for 6 years and in the community group homes for the behaviorally medically complex for the last 3 years as a part of the WCS team. So welcome to all of you. We can't wait to hear from you. And we're really, on behalf of all of us, you guys, we're really, really honored and proud to have you as a part of our team.
One final announcement before they go on, please put your cell phones on silent or muted so that we don't distract our wonderful presenters.
We are. Yeah. Yeah. So guys, Woods Community Services was started approximately 3 years ago when ODP and a few other providers came to our CEO and a few other people. Our CEO is Monica Moser, and they had realized that there was a need for adult services for people who were stuck in hospital settings that had nowhere else to go. So we opened WCS in order to facilitate relationships to help people who had not only psychiatric diagnoses, but also had medical diagnoses. So there were system barriers that we saw at first that we had to overcome. There was definitely a lack of mental health services in the community living arrangements. The national average for a mental health appointment is 67 days with a new patient. Even in the hospital setting, mental health was only given in increments of half hours, maybe once monthly. There's also a lack of IDA or IDD and ASD expertise in the hospital settings. This is because of lack of training for physicians. There's also barriers to communication. There's difficulty in finding the right placements when you transition from child and adolescent RTF services into adult services. There's inconsistencies in supports and staff members. There is quite a high turnover for adults that have medical complexities along with mental health, psychiatry diagnoses and behaviors. So the longer that you were staying in the hospital, we found that it led to a lack of care. There was never anyone looking at the medication or the pharmacology. Once you were on medications, you stayed on these medications. The longer the hospital stays, it's obviously becomes more financial a burden to people. And it led to less health care overall. So people were essentially being admitted to the hospital for a medical problem, and because they had nowhere to go, they were lengthy stays in the hospital. So at WCS, we started to look at not can we support this individual, but how do we instill services for this individual to be serviced? The people that we serve are high acuity level. We serve GI issues, people who are G-tube fed, or their entire medication regimen is put through a G-tube. They are on complete and total nutrition through their G-tube. Some individuals require, Esmond is going to speak to this more, but some people require even water being fed through their G-tube in order to decrease their lab values. There are failed multiple trials of people who were served in other facilities and other CLA homes. We were often seeing families that said that they felt like they lost a sense of control over their lives for some of the property destruction that their children were having in their homes. But more importantly, there was a lot of confusion when it came to overall health care. We serve people who not only have medical complexities, but also have psychiatric and behavioral challenges. We have clients that are on ECT therapy. We have clients that take prescriptions. And if anybody knows anything about Ativan, one of our clients is on 21.5 milligrams of Ativan. He suffers from catatonia. We have clients that have a gene depletion syndrome, which also leads to how they metabolize medication. So we look at that. There was also a huge need for medical adjustments that were just not being met at the level that they were at the hospital, in the hospital settings, or at other previous RTFs. We also serve people who have a history of struggling with their families with routine interventions for healthcare. Dental is a huge one. They just didn't have the necessary resources to have their child seen by a dentist or a doctor that was able to communicate effectively and deal with an IDD client or an ASD client. The population that we serve has also had a history of extending hospital stays. We've had one client that was in the hospital for 4 years, another 3, another 2. Has been no past success for them. So WCS pushes in services for individuals. When we first get an admission or a referral for an admission for WCS, we take a look at it from an interdisciplinary team evaluation. Both Keelin and myself, along with our CEO and our admissions department, again, we have how can we serve this individual in our homes? We use an integrated primary healthcare approach, mental health care approach, and nursing approach to promote holistic and continued health promotion for every individual. Our interdisciplinary team coordinates education for all of our individuals and families. We let them know why we're doing things, how we're doing things, and when we're doing things. So we do have psychiatric and medication management. We do have an emphasis on polypharmacy. We try to decrease medications whenever it is possible. We have nursing services. I have often stayed in the home with our residents or practically lived in the homes to make sure that they were okay. Our clinical services are always available to our individuals, and especially in crisis, Keelin will often go to the homes to intervene when there is a crisis situation. We use behavior interventions to decrease challenging behaviors. This is everything from de-escalating with talking to our Eucaro pads are also used to just listening to music sometimes. All of our clients have access to our medical center, our dental center, and our outpatient clinic, which has also helped greatly integrate healthcare for these individuals. We also have highly trained staff. We do not have a huge turnover of staff. It is because they get to know the clients, they fall in love with our clients, and they know how to de-escalate and use those techniques to work for the client and themselves. All of our staff have at least a bachelor or a master's level degree, and they have all been in the IDD, ASD, behaviorally complex experience for at least 1 year. Now I'm going to turn it over to Keelin.
All right, so I'm going to talk about some case examples. Hold on. Why isn't this working? Okay. So the first individual I want to talk about is JD. He came to us back in November of 2022 when he was about 21 and a half years old. Prior to coming to us, he had an extensive history of multiple psychiatric hospitalizations at both Kids Peace and Foundations, and was at Melmark in their RTF placement since September 2018. While at Melmark, he had daily episodes of both self-injury and aggression. He was restrained from 0 to 8 times per day at Melmark, which lasted anywhere from 20 seconds to 3 minutes. And most of those restraints were your face-up floor control. He had 2-to-1 staffing, but oftentimes additional staff were required in order to support him during his behavioral crises. In addition, he requires the use of a full helmet. So he has 2 helmets. They're hard helmets. One has a complete face mask, which he wears pretty much at all times except when eating or sleeping. And the second one is open. It has an open face, so just on the head, which he wears at meal times. And he was prescribed that by the medical doctor while he was at Melmark to prevent injury due to the intensity of his self-injurious behaviors. So fast forward to when he came to us, we are continuing to look at his challenging behaviors of self-injury. This is divided into 2 distinct categories: head banging, which is any instance or attempt of hitting his head on a hard surface such as a wall, the door, the floor, the table, and then other self-injury. So this looks like slapping himself with an open or closed hand on his head with enough force to cause an audible sound. In addition, we are tracking and addressing behaviors of physical aggression as well as property destruction. Triggers to challenging behaviors include denied immediate access to preferred items, communication stress, or inability to communicate his wants or needs. He is verbal, but often speaks very softly, so it's difficult to understand. In addition, he often does not have the words to express what is really bothering him. So clinician, staff, supervisor are really working with him to enhance his communication. The acuity around him is often a stressor, especially when he was at Melmark. So if others were in crisis, this would often cause him to be in distress and be in crisis as well. So here at WCS, he is in a 2-person group home. At first, he was in just a 1-person group home for probably the first year and a half of being here, just for him to get comfortable, get to know us. And that way we're decreasing that overstimulating environment that we know will trigger him. Meal times, new or unfamiliar staff can also be a trigger. So again, as Katrina spoke to earlier, he has had the same core group of staff since day 1 of WCS, which has been huge in helping him remain some kind of familiarity with staff as well as behavioral stability. Changes in routines or schedules could be a trigger, non-preferred task demands, but a majority of his behaviors seem to occur from left field. He might be calm, relaxed, sitting on the couch, and out of nowhere, he just abruptly engages in the behavior. So always kind of working with staff to identify any identifiable antecedents is really important. So the work that we're doing here at WCS with JD include individual therapy sessions. So the clinician is pushed into the home. Initially, he was receiving probably daily individual therapy sessions and staff consultation, and that has gradually faded to twice per week. Once a week is meeting with the clinician one-on-one to work on skill development, coping skills, replacement behaviors. And the other time is really focused on staff consultation, observation, and coaching to make sure that staff are trained and are following that behavior support plan. Sessions focus on increasing communication, helping him with transitions, increasing frustration tolerance and anger management, and using coping skills and replacement behaviors to improve his emotion regulation. So that the development of his behavior support plan has been key. He's been a 3-to-1 staffing ratio since admission. We took the 2-to-1 that he was receiving, but then really looked at it that when he was in crisis, he's going to need more staff. So rather than take a risk, we're going to play it safe and give him that additional staff around the clock to make sure he's supported at all times. In addition, due to his severe head banging, there are pads on the walls and the headboard in his bedroom, as well as common areas that he engaged in head banging for his safety. Staff are trained and use Eukaru pads to protect him when engaging in self-injury. We continue to use the prescribed helmet. However, he has now made progress so that he does not wear that at all times. In fact, it's used pretty infrequently now, pretty much only when he has a behavior or a known identifiable trigger is occurring will staff prompt him to put on his helmet. He can now remove it on his own as well. So that's been a success story for our staff. The use of physical restraints, I'll get to that data in a minute. And then bean bags are placed throughout the home. We have really large bean bags. One is in his bedroom, one is in the living room, and that has been a really important calming and coping strategy for JD. He really enjoys kind of lounging on the bean bag, taking some space and de-escalating. offering choices, and of course, a positive reinforcement and praise system, which includes his favorites such as Teletubbies, watching Barney, listening to music, and singing nursery rhymes. So this is his progress since admission. So as you can see, he was admitted in late November of 2022, and we really were able to collect good baseline data in December. He started off having a high frequency of behaviors in the 50s as he got to know our staff, our program, and we got to know him. Over time, with the consistency of staff and the implementation of the behavior support plan, the trajectory of those behaviors decreased for both frequency of behaviors as well as frequency of the use of eukaryopads and restraints. So currently, he's restrained only a handful of times per month, like between 1 and 3, and eukaryopads are also used pretty infrequently as well. There was a spike in April, which was due to allergy season. So he tends to spike in April surrounding allergies. But otherwise, he's pretty much, knock on wood, been behaviorally stable for the past year or so. All right, Vida, I think you have GK. No, Kate told out his business.
Sorry. So our next case study is about GK. He's a 24-year-old male with autism, intellectual disability, intermittent explosive disorder, absent seizures, obesity, and dyslipidemia. His clinical presentation was mainly characterized by intense physical aggression and property distraction. He received intensive levels of treatment at an RTF placement, and he did respond very well in the past to intensive supervision and structure at an RTF level of care. So when GK was being transitioned from children's program to the adult program, he moved into a community group home. He had a difficulty in his transition. The aggression started coming back, so he was hospitalized because of the physical aggression. His inpatient stay was further complicated by multiple restraints and chemical restraints. Behavior escalation, lack of disposition resources prolonged his hospitalization. He stayed actually at the hospital for over a year. So Woods was approached by a multi-system team to develop a community-based home for GK to meet both his complex behavior and emotional needs. So when GK came to WCS, he benefited from the intensive behavior strategies at WCS. His care was more personalized. He's actually been in the home for 3 years now. He has been stable for nearly 2 years, but there was a significant decompensation in his psychiatric presentation. He had clear episodes of mania and increased frequency in the cycles of intermittent explosive behavior. So he needed crisis intervention, medication changes, clinical support, and he was still able to stay in the community. We did staff training, intensive behavior strategies, consistent staffing were used. He also received positive reinforcement, and he has a daily activity that he engages in, which has been very helpful for him. Right now, he's able to independently use his coping skills when he's upset. He continues to receive integrated care from both medical and psychiatric services, and he is engaged in community-based activities. He goes to church, he goes to bowling, he goes to the Y. So he's doing pretty well after his decompensation. Right now, he's doing pretty good. Our next case study is on MR, who is another 28-year-old male with autism, mood disorder, ID, and anxiety. He lived at home with his parents. He has a history of physical aggression, property destruction, and self-injurious behavior. These behaviors got worse during COVID. Aggression generally towards parents and the staff that comes home to help anytime he's denied immediate access. The behavior outburst was not frequent, but when he has the behaviors, the intensity was so high, with the property destruction leading to multiple hospitalizations. His last hospitalization was occurred after he punched a glass frame, causing lacerations to the forehead and hands. He had to stay at the hospital for 2 years, and his stay was also complicated by multiple chemical restraints due to the intensity of his physical aggression. During his admission to Woods, MR looked very sedated with no personality. The problem was he was over-medicated. He was on a total of 10 medications. 7 were scheduled, 3 PRN. All these medications were at the highest dose required. So after he was admitted at WCS, he responded well to the structure, supervision, and behavior intervention. This helped decrease his intensity and frequency of maladaptive behaviors. So we started to decrease the medications. All the PRN medication, Haldol, Thorazine, Cogentin were discontinued. Melatonin was also discontinued. Hydroxyzine and gabapentin were gradually tapered. The Klonopin, lithium, and Zyprexa, the doses were all cut in half. And now we've started with the Depakote taper. He's now on 1,500 milligrams per day instead of 1,750 that he was. Now when you see MR, he has occasional behavior outbursts. The frequency and intensity are very low. He tries to be funny. Though he has communication limitations, he tries to engage in activities with us, and he's very, very personable. And actually, it's very rewarding to see him like that compared to where he was before. Yes.
So the next case I'm going to bring to you is a new model that we try to adopt here at Woods is the Woods Hospital at Home model. As the previous presenters noted, that we have a lot of clients that comes in, and in many cases, they have very prolonged hospitalizations, not because they're not stable to get out, but because of the behavior and all the other medical comorbidities. They find it very difficult to find disposition for them to go to where they can be managed. So with the Woods Hospital at Home model, the goal is to create a patient-centered model where you develop care around that particular client, not so much around a program that we have that they fit into. We kind of reverse that model where we look at the client and try to develop a program to fit them as opposed to the other way around. In developing those programs, sometimes it can be extensive. The homes are usually either bought or renovated to accommodate medical equipment. A lot of times the hallways are enlarged, the doorways and the bathroom has to be kind of remodeled to make sure that all the equipment that the clients would need would be accommodated within the context of their home. So like I said before, the whole person integrated care system is wrapping that model around that client, not so much fitting the client within a model that we already have. Because in many, many cases, some of the clients that comes to us, they don't fit within the model that is already laid out at Woods. We have to create new models to bring them into our system of care. So case study, we have this new client that came to us, AH, 15-year-old male, diagnosed with this rare condition called ROHAD syndrome. And ROHAD stands for rapid onset obesity with hypoventilation, hypothalamic dysfunction, and autonomic dysregulation syndrome. This is a very, very, very rare syndrome. And I think there is less than 100 cases worldwide with this syndrome. And we have one of the only cases, I think, in Pennsylvania with that syndrome. Before he came to us, he was at CHOP for 4 years. Prior to going to CHOP, he was there for a previous illness, just a very mild illness, but because of his behavioral issues, he went back home for approximately 48 hours. His parents couldn't manage it at home, so he was readmitted back to CHOP, and he spent the next 4 years of his life there until he was able to be integrated into the Woods system of care. Like I said, ROHAD is a rare life-threatening syndrome that results in rapid onset obesity, hypothalamic dysfunction, which causes you to have hypothyroidism, which creates fatigue and rapid weight loss, hot and cold intolerance, which sometimes can create some behaviors, hypo or hyponatremia, because they have very hard time regulating the electrolytes, hypoventilation, and in AH case, he is ventilator dependent. He also suffers from bradycardia and bowel disturbances. He is both a very medically and behaviorally complex patient. He's also very, very challenging to manage. Medically, he is chronic respiratory failure, central hypoventilation. He has a tracheostomy that is chronic for him, and he is 100% vent dependent. If he's off ventilator, from our own experiences with him for a very short period of time, he can actually lose consciousness. We have already experienced that here at Woods just one time, and I thought that one time was too many because it was a very, very scary occurrence. But within the context of the hospital at home model, we were able to manage it without having him readmitted to the hospital. He also has a G-tube that we use for supplemental feeding. He takes a PO diet, the diet by mouth, but on many occasions, because of his dysregulation with his electrolytes, we on many days would have to supplement his fluid intake with free water with an average of 14 to 1800 cc's of fluid, depend on his lab results. So he gets chemistries for his electrolyte balance every 2 weeks or more frequently if indicated, and we adjust his amount of fluid based on his sodium levels. He also has a history of bradycardia, and because of some of his medication for behaviors, he has what you call a QTC complex that can be widened, and when that happens, you can actually drop some heartbeats, which can cause you to get really, really slow heart rate, which can be detrimental. So he gets monthly EKGs to manage or to monitor his QT intervals and make sure that they're within normal ranges. This is just a copy of one of his lab results, and to us, it was a very telling when he came in within the first 2 weeks that he was here. He had a lot of behavioral issues, which result in a lot of self-induced vomiting. Because of that, his electrolytes was totally off. His sodium in itself at his highest point, even at one point higher than it has been in the hospital, was at 165, which put him at a risk for seizures. In many cases at Woods, we would have sent that person back to the hospital. But with AH case, we were afraid that if we readmitted him, he would not have come back to us. So with some very crafty manipulating of his D-tube and fluid balance, we were able to get his sodium back down to normal range, and it has been there since. He came to us in the first week of June, and he has been here since then. His numbers are stable. When AH came to us, our biggest goal was to prevent hospitalization within the first 30 days. We have accomplished that. We are almost 3 months out, a little over 3 months out, and our goal now is to try to see if we can have him here for a very long, fulfilling life afterwards. One of the things that we had to do when he came in, he has several specialists that he follows up with, including GI, endocrine, and pulmonology. Because of Anthony's unique medical complexity and behavioral needs, we as a team made the decision, instead of transporting him back to Philadelphia for multiple appointments to his specialists, we decided to adopt a virtual means of his appointments. His first appointment was with pulmonology. It went extremely well, and they were very impressed with his care here at Woods. All labs drawn is done at site at his residence. Physical, behavioral, psych therapy, psych visit from the psych provider, my visits, everything are done within his home until we think he's safe and feasible for him to travel outside of his own environment. A lot of his behaviors, it can be very, if you're not used to AH, it can be very scary if you walk in for the first time. Sometimes he has profound agitation with self-harm, head banging, self-induced vomiting. He would pull out his trach sometimes multiple times, 5, 6, 7, 8 times a day, and it has to be replaced. Most of this staff has been beaten, kicked, spit on, headbutt. Anything he can do to trigger a response, he'll do it. But the staff now has gotten used to him, and they could kind of almost anticipate his behaviors, and they know not to overreact and respond very positive to him. And then Keelin, if I'm not mistaken, a lot of his behaviors, they're better managed now than when he initially got admitted to us. He still requires intensive staff support, one-to-one nursing. Usually 2 to 3 psych techs are in the house with him. He is on many days 4-point restraints, just to make sure that he does not pull out his life-maintaining medical equipment, i.e. trach. He is on several PRN medication, which we have been trying to work back on. He has been on Benadryl, Clonidine, Ativan, olanzapine, Haldol. Those are just PRN medication. We, in many cases, have to use 4 lines of PRN medications for him. That has been kind of worked into where we are pulling back on that and trying to adjust his meds. The psych team was very instrumental in doing a genomine to kind of check to see what medication that he would best respond to. And I think we have had some results with that. For behavioral updates, he still requires intensive staffing support from 2 psych techs, one-on-one critical care nurse. They're starting to pull back on his meds from time to time, giving a little bit of time. They're trying to fade back on some of his restraints. He's doing a lot better with that. His Versed, if I'm not mistaken, that was discontinued. The Versed, Haldol, Clonidine, Ativan, they are pretty much discontinued. So that 4 lines of medication that we were using to try to control his behavior, those are pretty much out, and he's doing a lot better. He rarely gets PRN medication at bedtime except for the Benadryl, and he's making slow but steady progress. And now that he's a little bit more medically stable, the behavioral health and the psych team can work with him more intensively to kind of get better results. Like I mentioned earlier, Rohat's arrest syndrome, very rare, about 100 cases. We only have the case that's in Pennsylvania. It's usually diagnosed sometime between the age of somewhere from 0 to 9 years old, but the onset is usually somewhere within early childhood. Most patients with Rohat's life expectancy is somewhere around 10 years. But with really great and intensive patient-focused care, they can live for much longer. And in AH case, our goal for him is to make sure or try to ensure that he has a long, productive, fulfilling life here at Woods. That's it. Thank you.
Thank you. So we do have time for questions. Do you have any questions about the model? Yeah.
I have a question for Dr. Milligan primarily. It's about outcome measures. Have you identified any reliable outcome measures other than target behaviors to measure the efficacy of treatment?
Not yet. It's definitely something that we're looking at. And I have some ideas, but nothing has been implemented yet to this.
We struggle as well, so when you find things, if you could share.
Yes, definitely. We should collaborate, Dr. Mills.
Other questions? Tests to identify.
Yes, for AH in particular, that is what we call the genome, and that's what we did. It helped us narrow based on their gene and way they metabolize medication, what medications are best for them. So that is what we utilize.
Any other questions? All of our. A lot of questions. So, awesome. I love this. I love seeing that they're doing so well. You are tracking incidents. Are you also tracking skill development? So, because I didn't see any of that presented, and that's kind of the other side of the coin. It's not just about reduction in target behaviors, but kind of what skills they're developing in terms of replacement skills or anything.
So we just switched in June of this year to daily data sheets. So that will give us more information than just incident reports. So then we're tracking every single day, mild to significant behaviors for the individual, some of which may never have made it to an incident report if it was easily redirected or it was able to be stopped. So I'm hoping as we get staff and clinicians comfortable with daily data collection, that hopefully we can transition to also tracking a positive replacement behavior as well. Our team is also implementing PBIS probably at the start of January 2025. We're in training now. Lead coaches were just trained. We're working on staff coach training and then DSP training. So I'm hoping with that implementation, we can kind of show the why, as opposed to just the decrease of behavior, but the why in terms of the use of visual supports, praise, prompting, all of that positive reinforcement as well.
More questions? Oh, I was about to say going once.
I have a question, Esmond, for you about the use of PRN medications and maybe Vida as well. What regulations do you operate under, and how is it that you're able to have free access to the use of these restrictive measures?
Oh, okay. So most of the people with PRN medications that they came to us with it. So we try to find, I think it's part of our regulation when we are receiving them, because we have to stabilize them before we can take off any medication or start implementing what we are using. So most of them come in with those PRN medications. It's what they were doing before the admission. We continue, try to put in replacement behaviors to manage their behaviors, and then we start taking them off the PRN medication. I think Monica can also help with this.
I was actually gonna ask if Monica wanted to add this.
We follow the 64 regulations, we work very closely with the clinical director in general, and
People online can't hear you.
which is approved, the waiver we applied for, which is approved through Office of Developmental Programs, and that's how we build that into their program, and we slowly taper it. But we have the waiver written into the program for the use of the PRN chemical restraints.
So it's actually.
As well as the physical restraints, some of our individuals come in with the hand mitts, with the helmet, all of that is a waiver applied through ODP.
And so that's not like in an individualized plan, it's in the program.
No, it's all individualized.
The use of it.
It's all individualized, the use of the chemical or the physical.
And if I recall correctly, at least when one person was coming in, they had to have that written plan in place prior to allow it for admission because of the regulation, so it all has to be in place, ready to go, they can't do it once the person is admitted.
Right.
A lot of times, you have to have those two restraints in place before you can even put that into a plan. 9 out of 10 times we're bypassing that upon admission and having that all written in and then the waiver applied with ODP. ODP's clinical department is very involved in our admission process. Almost 99% of our referrals come directly from ODP, from Amy Nemro herself. So we're working collaboratively with that team. We've not really had any barriers in getting them approved in their plans. It's actually going through their human rights committee as well as ours.
So that question for people online was, how many people do you serve and how long do they stay with you?
We opened up our first group home, August 21st, 2021 for GK. All of our we have 19 individuals right now, and they have all remained in our program. No one has been discharged as of yet.
So can I just speak to the PRN usage for 1 second to add on to Monica? A PRN always has to be assessed by a nurse. So, and given by the nurse. So that's also written in their plan. So why we have staff trained in medication training, they can administer our meds. They would have to call me in order to get a PRN on board.
So for Thoroughhead, what's the team's target goal for him to allow him to travel outside the home for a longer period of time? You know, he has a portable van. PRNs are decreased, behaviors are somewhat decreased. So do you have a target goal, target goals?
The goal really is with him right now to onboard PT, OT, and speech so that we are able to take him out in the community. We also have a handicapped wheelchair accessible transportation to get him out and about. So as soon as we can onboard all of those therapies, we'll have better outcomes.
The other piece with that from a medical perspective, and AH has a propensity to get mucus plugs. His portable vents are not humidified. So usually in his case, the weather and climate has a barrier in how long we can keep him on those portable vents. So if we're going to attempt him traveling in the community, we have to look at the time of the year and the months where we'll be most likely to succeed in integrating him in the community without having any adverse reaction from mucus plug, i.e. because his air is not humidified. So that is one of the things that we have to assess before we can make that clinical decision.
Hello, everyone. My question is more in line with, has there been any case studies where an individual actually went from a group home setting back to RTF placement? And the reason why I'm asking that is because just based off the observations and during the transitional period, with the staff, and when the individual was at the group home, it was more controlled environment. The staff did very well with the individual in the group home setting, and the behaviors were controlled. However, with them returning at the RTF facility, the behaviors increased. So I just wanted to know if that's been something that's been observed or looked into.
We haven't had any discharges, and if they were discharging, they would discharge to a more independent setting. So they're never going to go from a community home back to an RTF unless there is some reason why their plan cannot be individualized anymore, and we would have to do that.
And I think that's exactly what it is, because they have those medical complexities as well, but it was controlled in that environment, in the group home. It's only my thing.
Yeah, I
That's
think
just
that
all I
there
can
were
say.
some Brian's House and Mollywood's case studies that could be shared, but not the WCS program.
Yeah.
Do you guys have family involvement, and what does that look like in? How do you kind of, I know the challenges sometimes in residential services, do you guys experience those same things? Especially when there's more than one individual in a home?
I would say it's similar to your RTF experience in that it varies greatly. We have some families who are highly involved and highly invested. They get weekly updates. They come for dinner visits, weekend visits. They take their child to the beach, to Rita's, you name it. They're here working side by side with us. And then we have the other extreme where it's really hard even just to get contact with the family to provide an update or get consent for a restricted procedure or invite them to an ISD-BSD meeting. So it kind of runs the same gamut, I think, that RTF experience.
Great amount of
questions.
success. We've had a great amount of success with our clinicians sending those very, very involved families their weekly updates and keeping them involved in all the team process. But I would say that clinical really does take the lead on the communication with family and providing them weekly updates on Friday, and that seems to keep all the team members collectively as one.
So I have one more question, sorry. So I will only give you one more question. So you guys are community living arrangement, medically complex. Brian's House is a lower level of care. I know you guys have not discharged yet. Are you guys collaborating with Brian's House in the event that it would be kind of a stream, a lesser level of care to step down to?
I know that Monica has been in talks with Brian's House for that very reason.
Yeah, ODP recently is starting to implement performance-based contracting, and Lori and I are overseeing that whole process together as one. So yeah, Lori and I meet bi-weekly, and we do discuss if there are currently any individuals that can be tapered down into her program. And again, it just really nicely aligns itself with the performance-based contracting. So that's certainly coming down the pike for WCS and for Brian's House.
I don't have a question. I just wanted to commend you all for the amazing work that you do. And it's so special to give these individuals an opportunity to have as normal of a life as possible and outside of the hospital where some of them were for years. And it's just really hard work what you guys are doing. So awesome for everyone.